my friends and colleagues all over the world, and I'd like to welcome you to this new episode, the EGVRS Around the Retina World, where we are going to be meeting with a lot of distinguished guests from all over the world in the field of the retina, both medical and surgical retina. And today in specific, I'm honored to be having one of the real experts in the field, one of the few who really combines medical and surgical retina together, and this is a rarity in our field. I'll be hosting with great pleasure Professor Carsten Meyer. Professor Meyer is the third generation ophthalmologist, and I'm sure we're going to be talking about this soon. Professor Meyer had his medical studies in 3 countries, which is again very intriguing, in Germany, in Austria, and the United Kingdom. And then he had his fellowship in vitreoretinal surgery at the very prestigious Duke Eye Center in North Carolina. And then he went back to Germany, but currently Professor Meyer is practicing from Switzerland. Professor Meyer had more than 40 textbook chapters, and some of those books have had a lot of prestigious awards, including the book by Sebag on the vitreous, and also the Ryan Retina book. Professor Meyer has also authored the very famous textbook on optical coherence tomography in macular diseases, which has been a Springer publisher, a blockbuster for so many years. Dr. Meyer has also more than 370 publications in peer-reviewed journals, and Professor Meyer has been awarded so many prestigious international awards, including the American Academy of Ophthalmology Achievement Award, and recently has been appointed to the Retina Hall of Fame 2021. So without further ado, I give you Professor Meyer. Professor Meyer, welcome to this episode. Really glad to have you tonight.
Thank you very much. It's my pleasure to be invited to your webinar, and I'm really glad to see you.
Thank you very much. Any of what I mentioned sounds right?
This is correct. This is correct. So I was really lucky that I was born into a family of ophthalmology with a lot of ophthalmologists. I didn't have actually the choice either to become a farmer. So we have a lot of farmers and ophthalmologists in our family. And actually, my grandfather started to be an ophthalmologist, and later my father and his twin, they also became ophthalmologists. And sometimes they were married to an ophthalmologist. And I also have a lot of cousins who studied medicine and became ophthalmologists. So in the beginning, it was actually kind of burden for me to go to medical school and then to go for ophthalmology. But I was for the first time at the Duke Eye Center doing an internship where Robert Mackemer invited me. Robert Mackemer was actually a young professor in Germany, in Göttingen, together with my father. And they were really close friends. And when he invited me to the Duke's Eye Center, that was for me with Bruce Shields in glaucoma, it was just an eye opener. And this was so phenomenal that I really decided I also want to become an ophthalmologist.
Okay, so I mean, I guess it runs in families, like they say. And I myself had my father as not an ophthalmologist, but in the medical field, he was a professor of endocrinology. However, this is a different field, but still, I think when your upbringing is in a house filled with doctors, it's a no-brainer. You usually become one. But let me ask you, you have studied medicine in several countries. How come is this?
Well, this is very uncommon in Germany, and especially in Germany, it's very difficult to switch between universities during medical school. Well, but again, my father was my role model and my grandfather, and they told me that, you know, in the winter they were studying in Austria in Innsbruck, and in summer they went to the Baltic Sea, to Kiel, to learn to sail. And I tried to follow their role model, and I was quite successful. So I was also lucky to study in Innsbruck, and actually to study abroad was easier from the system than to switch between universities within Germany. And yes, I was lucky that I had the chance to go to a couple of countries and also to learn about different medical systems. I learned about the British system, the German system, also the Swiss system. And I think this really helped me a lot to see different approaches, how you can how you can run your clinics.
Okay, and what are the challenges you have met in the beginning of your career? I mean, when you started practicing in Germany, you said there are so many different systems, and now you're practicing in Switzerland. So is there a big difference between the practice in Germany and Switzerland?
It is. Well, on the one side, we have in Switzerland quite a high number of ophthalmologists from other countries, because they only have a limited number of universities in Switzerland, and we need more highly trained physicians and surgeons also in Switzerland, which is basically the German system. In Germany, you have just a limited number of surgeons, and especially retina surgeons, but they are trained in a high volume approach, and therefore you get used to most procedures quite well. And therefore Swiss hospitals love to recruit foreigners with a lot of experience in surgery and within other countries to come here. The big advantage is in Switzerland that a lot of mistakes that have been done in the German system over the past 10 or 20 years, they haven't been done so far. So for me, I still can practice in the approach or my father or my grandfather performed treated their patients. So for me, the patient comes first and not the insurance company or something else. And I'm very thankful that we can perform such a high quality treatment to our patients.
Okay, so you feel more free practicing this way in Switzerland than
Yes.
to be in Germany.
Yes.
You are in the German part of Switzerland?
Yes.
Okay, so mainly the population speaks German there.
Right. But also here Italian. So we also have Italian.
Okay, all right. So, and what about is your center a point of attraction for for the patients? Is it a recruiting center? Is it a tertiary referral center? How do you describe your center and the town where your center is?
Well, I work now in Chur, which is the government city of the county of Graubünden, which is in the eastern part of Switzerland, close to the border to Austria. And here we have a lot of mountains already. So we have a couple of satellites in other villages and in other cities. So I started with a close friend in Davos. He has been performing their ophthalmology and anterior segment surgery over the past 20 years. And since I came to Graubünden, I started also to do medical retina and surgical retina. And we just opened a new surgical center. So I will be the first retina surgeon within this county of Graubünden, because until now, the patients had to drive. So they had to drive to Zurich, where I also had the chance to do retina surgery at the Trimli Spital and other hospitals. But nowadays you can perform most surgeries as outpatient surgery, and therefore we have decided, and the patient load is so high in Graubünden for retina surgery that we just built our own retina OR, and after Easter we will start performing retina surgery also in Graubünden.
Perfect. Do you have your family with you in this city?
Actually, not. This is the school system is a little bit different, and therefore my wife and my 2 children, they are still in Germany. I mean, they come back and forward, so we still live in both countries.
Okay.
But my youngest son, he's just finishing high school with his Abitur this summer, and then basically we are free. I don't know where they want to apply for university and where they want to go and what is their plans for the future. But in a year from now, the center of our family will be in Switzerland.
And your eldest, is he at university already?
Well, actually, she was applying, and she's a little bit challenging case in the moment for us, because she was actually, a year ago, she even wrote her first paper with me in ophthalmology, the American Journal, and she was really talented. But unfortunately, she developed very serious seizures over the past summer.
Oh, I'm sorry to hear.
And
that.
she's still, well, she's recovering. She's really doing well, but it's a long way to go. It's not like cataract surgery or retina surgery where you recover in a couple of weeks or months. So we have now 9 months struggling with her, but she's getting along very well. And well, we hope that she still can go to university at a later stage.
Yes, hopefully, and become as renowned as her father in the field of ophthalmology as well.
Yeah.
A very speedy recovery.
Yes.
All right. So with that, we will end the first part of this episode, and we'll take a very short break, and we'll come back with the scientific part of this episode tonight. Thank you, Professor Meyer.
Thank you.
We're back with Professor Meyer, and this is the second part of this episode. Professor Meyer has been pioneering a very, very elegant technique in cases of refractory, and I guess also is using it now for primary macular holes regarding the detachment, the macular detachment. He has a very peculiar theory about that, and he has been the main author of the Apostle study. And tonight's talk is going to be about this technique in refractory macular holes. So, Professor Meyer, please share your screen and let us see your technique, please.
Well, thank you very much for this kind invitation to present you our new theory about subretinal hydrodissection to close large macular holes. I have no financial disclosures, and we all know. So, I mean, I don't want to change the theory about the evolution of macular holes. And I learned a lot from Jerry Seebeck, who was a close friend from my former chairman, Peter Kroll. And he visited us frequently in the University of Marburg and explained to us everything about the liquid, the posterior vitreous detachment and the development of epiretinal membrane and the formation of macular holes. And I also don't want to change the theory from the classic classification from Don Guess, or later on Godric, who showed us with his in vivo images of the OCT, how the evolution of macular holes develop. And when I did my fellowship at the Duke Eye Center, I learned a lot about the treatment of macular holes by vitrectomy at the Duke Eye Center. And when I returned, Robert encouraged me to continue with our studies on dyeing the vitreous, dyeing the epiretinal surface with numerous vital dyes, which we named later on chromovitrectomy. However, wait a minute, didn't we miss something? We know that the evolution of macular holes is epiretinal. So tangential traction of the vitreous will induce epiretinal membrane formation. And we also know if we release all epiretinal membranes by vitrectomy vital dyes, we will have a closure of nearly 95% or more. So my question is, why do we continue to treat persisting or refractory macular hole by an epiretinal approach? We put silicone oil on the macular hole thrombocytes. We put an ILM patch on top of the retina to seal the macular hole. And we hypothesize that the closure is prevented because we have firm adhesions of the retina and RPE that prevent the closure. Thus, the subretinal release of these adhesions will stretch the retina and close macular holes. I mean, this idea is not new, and I was exposed to this in 2002 when I attended my first GONE meeting in Montreux, where the new surgical approach was presented by Gonvos, Bove, and Thomas Wolfensberger. Well, at that time, it was a time of subretinal surgery. I was a fellow at Duke, where I worked with Cindy Toast and on limited and full macular translocation. So the approach, and I think we even had the same idea if we were working on the theory and techniques to detach the retina, to shift the retina downwards in limited and full macular translocation. And I recall conversations with Brooks McEwen that this technique might be feasible also to close macular holes. However, it was the time when also vital dyes showed the victory and about the closure of macular holes, and that they were really the resolution of the underlying pathology that did induce the macular holes. It took another 10 years nearly until the first publication of this Polish group was published. However, it wasn't published in the Retina Journal, and therefore nobody really paid attention. And it took another 7 years when Mandelkorn described this technique and called it for the first time macular hydrodissection. At the same times, another group from Canada, Roger Wong, described his technique, and in 2018 he described and published his first case series of 16 patients where he achieved a closure in all macular holes except two eyes. However, you must confess that this was just a single center approach, and it was still not so convincing to other surgeons to try this approach. I listened to one of his talks, and when I returned to Germany, I was seeing such a patient. This was a 83-year-old gentleman with a 2-year old macular hole. He had vitrectomy with vital dyes, and the gas tamponade was a silicone oil tamponade. Silicone oil was removed. And well, now he was sitting in front of me with a more than 1400 micron macular hole. There was no epiretinal membrane left on the surface to perform a patch, for example. And he was seriously this scotoma was irritating him quite a lot. And when I saw this patient and I recalled this talk from Roger Wong, I was thinking of my fellowship with Cindy Toes, where 20 years ago, I measured after subretinal fluid application in limited translocation, the shift of the retina. And this was 1600 microns, just by detaching the retina from above and stretching it downward. So why can't we use this approach in such a patient? I performed it for the first time, and I can show you here. It's a pretty forward surgery. So you go into the eye, and you can see here the large macular hole. The eye is vitrectomized, and to start with this, it's not necessary to do it all the time. I recommend to use a PFC bleb, because what you want to avoid is that you have a fast draining of the fluid that you inject under the retina, that it gets into contact with the macular hole, because then it starts rinsing through the macular hole and it's not expanding. I was amazed when I saw this patient 5 days after surgery. So you can see here this 1400 micron macular hole, 2 years old, was closed, and the contour of the macula appeared quite normal. I asked myself, well, is this really, was this just a lucky case? Is this repeatable? How feasible is this? And if you do this in a higher number, are there any secondary risks we are not aware of? I presented this case at a couple of meetings, including the Vail vitrectomy meeting in 2019. There's a video where I also demonstrated my approach. And we had a lot of discussion with a lot of friends up there. After I presented this video to a number of colleagues, I started the Apostle study with 12 colleagues from Germany who have performed this surgery over the past year. The goal of this first study was to evaluate the technique itself. So most physicians, they apply 3 subretinal blebs. They use BSS manually, some mechanically with a machine. All surgeons stated that it's very important that the edges of the macular hole, so at the rim of the macular hole, they completely detached, because if they are still connected, if they still have a connection with the RPE, closure can be difficult. Once the macular hole is freed, the closure behaves like a normal macular hole. Within 5 to 7 days, surgeons observed closure. We didn't observe any serious adverse events in the 41 cases. With less experience, the tamponade was predominantly gas, but also still some surgeons, 9 cases were done with silicone oil. To the parameters of the macular hole, you see that the duration was 17 months, and the aperture 1200 microns, and we achieved a closure of over 80% in this study. So the conclusion was from these 12 surgeons, yes, it's a feasible approach. It needs, most surgeons have enough experience to perform it. There's a small learning curve, and there was no serious complication rate in this study. These are our 12 apostles, and after we proposed our study, described it and evaluated it, numerous other colleagues contacted me for now an ongoing SEAL study. It's a more global perspective, where we have, like here from my co-fellow, also from Duke, Makoto from Japan, is applying the subretinal fluid in the subretinal space. But you see now it stops because you have rinsing of the subretinal fluid through the macular hole. Then you have to move to another spot to repeat it. Up to now, I have the data from 44 surgeons, more than 30 centers and 13 countries, with more than 150 cases. But basically, the preoperative parameters didn't change that much. The greatest outer diameter was 1200 microns. Most surgeons prefer a gas tamponade, and however, with more cases, we learned that not only idiopathic macular holes have been treated with this approach, but also 33 secondary macular holes. The preoperative parameters were basically equal. We also had a duration of close to 17 months and a logMAR of 1.16. The early post-operative measures determined also a closure rate of over 18%, 80%, and this is basically since 1 year, since I collect more and more patients, it was always above 80%. And we have a gain of 3.9 lines within the first 6 weeks of these patients. With more patients, we can perform a subgroup analysis, and you can see here that from the 152 patients, 25 remained open, so we have a closure rate of 83% in the study. However, as expected, idiopathic macular holes have a higher closure rate of nearly 90% with this technique, whereas secondary macular holes have a lower closure rate, but still of 60%. The macular holes that remain open were 7 times a very long duration of 20 to 96 months. So I assume that the retina is too stiff, and yes, you can detach the retina, but the stiffness of the retina prevents the closure of these macular holes. And another 10 cases had a diameter of 14 to 2,300 microns, and I assume that above 14 to 1,500 microns, this approach has some limitations, although we also have data from a closed macular holes with a diameter of more than 2000 microns. For the secondary macular holes, I was amazed because if you see the underlying pathology, 12 times high myopia, 6 times macular hole after
Professor
repeated
Meyer,
retinal
we
detection.
need to sum up because we're running
Yes.
out of time.
After trauma. So in conclusion, we can say that with this technique, we have a closure in 4 out of 5 macular holes. The post-operative gain of the vision is nearly 5 lines by all eyes. However, it is limited in secondary macular holes. Macular holes derive from traction of vitreous, and therefore a complete removal of the traction will close nearly all macular holes. Persisting macular holes may rely on secondary firm adhesions of the photoreceptor to subretinal adhesions, and therefore subretinal hydrodissection will release these firm adhesions, stretch the retina, and close persisting macular holes. Thank you very much.
Professor Meyer, a very elegant technique. I just have a few questions regarding the technique. So this is a technique only for refractory macular holes, or you use it on primary holes as well?
It has been done on primary macular holes as well, predominantly in eyes where you expect more firm adhesion of the retina to the RPE, such as uveitis or macular holes with drusen, so with combination with AMD. I've seen a couple of cases where surgeons applied subretinal fluid as their first choice.
Okay. And do you, for this technique, I mean, most of those patients are failed macular hole closure. So those patients had already had some kind of an ILM, whether completely peeled or flap. So if you have still an ILM, I mean, if it's not completely peeled, would you use it with this technique, or you just ignore it and go ahead with the technique?
Well, that's a very good question. I mean, I'm still a fan of the epiretinal patch, and we just wrote half a year a paper of a combination. So we combined an ILM patch with subretinal fluid. So it's kind of a triple procedure that you do a vitrectomy, an ILM patch, and at the end of the surgery also a release of the retina by applying subretinal fluid. So I think, you know, I mean, my point with this technique, this is not the technique that will close all macular holes, but my criticism, as I stated early on, is that I think for a long time, we were just facing macular holes from the epiretinal approach, from the epiretinal side. And somehow we did forget that also underneath the retina, there are secondary processes that might prevent the closure of the macular holes. And if you have done a proper ILM peeling, and if there's nothing remaining on the surface, and if no ILM is left to cover the macular hole, I think this technique offers a very nice and simple approach to try closure in these macular holes.
One last question. What is the largest macular hole and the oldest macular hole you think treating, whether with this technique or another technique, will help the patient see better? I mean, we see a lot of large macular holes, long-standing ones, and very large ones. And usually, even if those holes close, the patient will not regain vision. So what's your limits?
Well, I think, you know, I would say that a 2-year approach, 2-year persisting macular hole still can have a very favorable result. I think it's not necessary only the duration of the macular hole, but you also have to look at the OCT, how much of the photoreceptors, inner and outer segments are still visible. And therefore, I think, you know, I think macular holes up to 1200 microns have a very good chance to be closed with this technique. And I would do it even in macular holes of 2 to 3 years, but I would discuss the prognosis with the patient prior to surgery in detail.
Excellent. So before we go, can you tell me one funny situation you faced with one of your patients?
Oh, you mean with this technique? I mean, I think the greatest was that the patient came to my clinic and he was suddenly he could see his watch again because he had such a big scotoma centrally, and I think this is mainly the greatest burden for these patients with persisting macular holes, that they have a persisting central scotoma, and all the time where they try to face they want to face something, they have this limitation and they can't face, and they have this central scotoma. And with the closure of macular holes, they have a nice situation. And I don't remember what he found, but it just came to my mind that one of my patients, he after surgery, he was able to, he was not able to read, but only with a magnifier, but he found some old letters from school, and he reported me about it, and he was very happy about the surgical outcome.
Great. Thank you very much. It has been a real pleasure having you tonight. And we
Thank you very much.
See you in Egypt soon, hopefully.
I hope so too. It's on my list to visit you one day. Thank you very much.